Thank you so much, Professor Samah, and thank you so much, Professor Walid, for your kind introduction. And I really like the theme of this session because we will cross the borders of the treatment in type 1 diabetes, whether technology or insulin injections. But first of all, I would like to give big thank you to Professor Mohammed Hassanin for his great leadership in the DAR Alliance conference, as well as the great scientific committee for this great program. I have nothing to disclose regarding this session. But let me start with 3 consecutive slides and see where they're going to transfer your thinking into. So this is the first one, this is the second one, and this is the third one. So the leading question here is how to drive a safe fasting for those who are doing insulin pump therapy. So we've got different challenges during Ramadan fasting. So it's not just the blood glucose management, but the hyperglycemic risk, hyperglycemia, the blood glucose fluctuation, as well as lifestyle adjustment. And talking first to the open loop insulin pump therapy, we can see different publications coming from this region, either the Gulf or the MENA region, where we can see the settings of the insulin pump therapy. All of them can be easily reviewed over the international publications. The main point here, the occurrence of hyperglycemia in the first few hours before breaking the fast. Moreover, the hyperglycemia related to iftar meal. And here come the first publications about insulin settings, whether the basal insulin settings or bolus, and you can see the redistribution of basal insulin in open loop system where you have to decrease from 10 to 35% of insulin adjustment basal when you are using the fasting hours, and increasing the basal insulin in the iftar time to abolish the hyperglycemia post-iftar. And you can distinguish the difference between before and after Ramadan. But we've got the first low glucose suspend, the open loop insulin pumps, where you can see the suspension of insulin to prevent hypoglycemia during its occurrence. But technology improved, and then we're moving from the low glucose suspend into the predictive low glucose suspend features, where you can see another prediction of the hyperglycemia, preventing this from occurrence. And you can see also another publications from the open loop looking at the high glycemic, high fat and protein content, and how you can use the square and dual bolus and open loop pumps, where you can do the 50-50, the 60-40, or the 70-30 split. Are we going to do it with 20% increment or just the same amount of carb? And we have concluded in this study that you will have to do the 20% increment. And you can see also from the abstracts published in the ISPAD that the predictive low glucose suspend features were helpful to avoid hypoglycemia without mitigating the hyper into the non-fasting hours. Also, the Taraweeh prayers, it's part of the exercise where you can use the 10 target, the 10 basal, percentage, and the duration of timing. And here I'm talking about open loop pump. This is a technology lecture, so I have taken you from the first versions of open loop pump into the automated insulin deliveries. And those are the main backbones insulin pump therapy available in our region. And I'm really relying here on evidence, and the first and the only insulin pump where you can find evidence of the automated insulin delivery is the Medtronic 780G system. And just briefly, in order of the time, we can just look at the optimal setting of the AID system, active insulin time of 2 hours, and the blood glucose of 100 milligram per deciliter versus the control group where they had the relaxed setting with active insulin time of 3 hours and the blood glucose target of 120. And you can see that those who had the recommended and optimal setting, this was not on the expense of hypoglycemia, where you can see the green area reaching 82%, and not on the expense of time below range, where it maintained the same, and again, not on the expense of breaking the fast. Also, you can see here that the additional of add-on therapy or hypoglycemic with AID system can mitigate the postprandial hyperglycemia seen during iftar meal, and how those patients with the addition of the vildagliptin that did not compromise the hypoglycemia, but also you can have a better time in range by simply decreasing and making more relaxed ICR on those settings. And move to my dear friend, who's the next speaker, Dr. Mohammed Al-Sufyani, working for the 780G again in the Gulf area. And you can beautifully see the adaptation of the 780G between before Ramadan, Ramadan, and after Ramadan. I like this slide because you could not distinguish the difference at day one, before starting Ramadan, all the month, and even 7 days after Ramadan. So your eyes would not actually catch the difference. The green area will be maintained, statistically non-significant, looking at the algorithm, how it adapts even the lifestyle changes in Ramadan. And some 2 case studies looking also the difference between open loop, the traditional, as well as AID. And again, AID system wins by having better time and range. And you've got also a double target here, because we're not talking glycemic control, but we're talking fulfilling your religious belief, and you don't want to break the fast at this stage. And that's why you will see 780G wins in having the longest period of fasting Ramadan. Dr. Wanas, also from KSA, have looked into some case series of adolescent moving into Ramadan fasting, whether using the hybrid closed loop with the standard ACL, and then you can see again more and more green area, time and range is higher, and even if they're looking between the older version, as I have implicated, the 640 G pump, this is the open loop, versus the 780G, the AID, again, much statistically higher time and range, and this was not on the expense of hypoglycemia. And that's why from frequently asked question, how we're going to do the pump settings, and this is not only being asked from my country, Egypt, but have been asked from the Gulf states, Australia. They needed to know how to adjust the AID system during Ramadan. And that's why we came up with the consensus guidelines looking into the best recommendations, and those are based on real-world evidence versus clinical trials. And I would like to give a big thank you to the 13 expert panels from all over the world. You can see them where we have used those clinical evidence. It's already published. You can scan the QR code to help you look in full. It's not just looking into the settings, but it's everything pre-Ramadan, Ramadan, and even during Eid al-Adha. And you can see here the pre-Ramadan counseling, how you are looking into the settings. And the good thing that Medtronic also helped us to do those guidelines in 4 languages. And you can, again, scan the QR code, looking if you're using English, Arabic, French, and Turkish, and you've got the scanned QR code, you can check it. And allow me to show you those guidelines where you can simply pick up one of those brochures from the Medtronic booth outside your room. You can share it with your colleagues, as well as dietitian and nutritional and diabetes educators. Furthermore, we're not talking here about time and range, but because things are getting tighter and tighter. This is diabetes, so it's not just simply the time and range between the 70 and 180. But now we're talking the end of an average era, and we need to have a precise, more and more control, so it's getting tighter. And we're looking to have a time in tight range, and the new concept of time in normal glycemia between the 70 and 140. And the new guidelines will implicate it should be more than 50 and 55%, with a positive correlation between time and range and time in tight range or time in normal glycemia, and look also for the time in pregnancy range. So you will see the break time of the time and range into the light and the darker green colors, and now it's the 70 to 140 time in tight range, and the 140 to 180, which is the time in range. And now I have looked into how can we go into the time and tight range in those fasting in Ramadan. And then we have looked in both patients, either type 1 or type 2, those without micro and macrovascular complications, and they do not have any hypoglycemic attacks or DKA before enrollment in the study. So they're non-insulin treated type 2 and patients with type 1, either multiple daily injection with the continuous glucose monitoring, open loop system paradigm, the 640 or the Omnipod Dash insulin pump, also the AID, either using the 780G, which is majority of our cohort, versus those who are using Omnipod 5 or Tandem IQ control system. And then definitely we're going to analyze all the download, the care link, including the time in tight range in those patients. And this was our primary outcome, looking at the changes in those two. So if you're looking in those population between type 1 and type 2, those were mainly young adults with a duration of more than 5 years and an average sensory glucose value, which was a little bit statistically higher in those in type 1 rather than type 2. And again, definitely, as expected, it's not just the HbA1c or GMI, but even the coefficient of variation, looking at the whole population of type 1 versus type 2, where you can see the spikes is more common in those with type 1 diabetes. And breaking down the time and range, you can see also that the time and range was higher as a whole population, including those in MDI, open loop or closed loop type 1 diabetics. But just breaking down the table into MDI with the flash continuous glucose monitoring versus the open loop and the closed loop, you can see here statistically significant better sensor glucose values in those due to the automated insulin delivery. And this was reflected on the GMI as well as coefficient of variation, either if you are just comparing each group with another or all the groups as a whole with the AID system. And here is the breakdown of the time and tight range, where you can see the superiority of the automated insulin delivery of reaching the time and tight range even in Ramadan fasting, where those on the HCL system can reach more than the 55%, reaching at the end of Ramadan 62%, and this is in comparison to those with non-insulin treated patients with type 2 diabetes. So I just wanted to highlight here, this was definitely in comparison to the NDI and the sensor augmented pump therapy, where there is an increase in the total daily insulin dose, either basal bolus in the NDI, but the redistribution of the basal insulin in the open loop, and definitely the autocorrection and the basal insulin was increasing the automated insulin delivery to have the best glycemic outcome. And if you're just breaking down what is the time and tight range in each group, you can see that there was no statistical significant difference between the non-insulin treated patients as well as those who are using the AID system. Again, looking at the superiority of those systems in conducting safe fasting. So the numbers of fasted days, I'm just wrapping it up. Again, it was the best in those who are using AID system with no severe hypoglycemia, DKA, or hospital admissions. Again, there is the QR code if you need to scan it to look at the newest publication time and tight range in Ramadan fasting. So definitely technology is a game changer with less hypoglycemia, hyperglycemia, as well as coefficient of variation. You should trust the system. Here's the tango between the CGM and insulin pump to improve the flexibility of better Ramadan fasting. Definitely, this is not will be available without the education and support, and we should embrace the technology as a crucial rule for safe and Ramadan fasting. Definitely, this should be available for all people. And those, even with the limited resource countries, should have the availability to reach the technology. This is first the superiority of the effectiveness and the safety on those systems. And the question was that I was given to answer, does technology will have a better Ramadan fasting? Is it true or myth? I hope at the end I have shown you that definitely this is a truth. So I'm ending with the 3 slides. Those are the 2 hemispheres linked together. Behavioral intelligence of the patients, where they can have safe fasting, whether regard the meal content, the timing of the treatment versus the algorithmic intelligence. So this is the dual intelligence that we will have in the next few years. And this is not just simply the Ramadan lantern. Just look at the lantern. This is the what? The dotted blood glucose monitoring. The CGM will connect this. The algorithm will take over to connect the CGM together with insulin pump to have the best glycemic control. And you can see the fanus of Ramadan to enlighten the patient safe road of having good Ramadan fasting. The blood glucose is fluctuating, fasting is stable. So how are you going to bridge the gap using this technology? Thank you so much for listening, and I'm ready for any questions and answers.